So I'm going to introduce our panel. And I'll just get them to wave. So Glenda Peebles is our Aboriginal Liaison Coordinator. Her background is in social work. She works for the Manitoba Renal Program. So Gord Basraba is a renal pharmacist, and he works with the HSC renal program, and he might be looping in with us at some point if he isn't on telehealth right now, so he may be available for questions. Julia DeCosta is a renal dietitian with the Seven Oaks General Hospital, and Dr. Paul Clement is a nephrologist with the Seven Oaks General Hospital Renal Program, as well as the research director for the Chronic Disease Innovation Center and associate professor of medicine, Brady Faculty of Health Sciences.
Hi guys, welcome to the webinar. I'm Paul Clement. I'm one of the nephrologists here at Seven Oaks, and I'm going to be doing some of the presentation portion for Nikki, who is one of our transition coordinator nurses, who's actually ill today, unfortunately. So we're going to get started. As Amy had mentioned, we're going to get fairly simple. I went to school for a long time to learn that there are two kidneys on each side of the spine, so just to test that everyone's listening. Most of us have two, some of us has less. Usually located kind of in that back area. You can see that's fairly anatomically accurate, that diagram there at the top. And each kidney is about the size of our fists, anywhere from 9 on the small side to kind of 11 or 12 centimeters on each side in length. The kidneys have a lot of very complex functions. It's probably one of the more complex organs, despite what the heart specialists will tell you. They are able to replace heart function with a small implantable device, and we need this massive dialysis machine to replace the same function. Some of the metabolic, we'll call, function of the kidney are removing excess salt and water, keeping the body chemistry in balance, things like sodium, potassium, calcium, magnesium, all those biochemical factors are kept in very tight regulation, including acid-base balance, which is very important. The kidneys also have detoxifying function, so in terms of cleaning blood, getting rid of, breaking down certain medications and certain kind of metabolic byproducts of regular kind of cellular turnover within the body happens within the kidneys. And we have also hormonal functions responsible for, in addition to removing excess salt and water, controlling blood pressure, as well as helping make red blood cells in combination with the bone marrow. So there's a lot of very complex functions that the kidneys perform that we have to kind of help restore when the kidneys start to fail. Kidney function, obviously, as we get older, we lose some function over time. However, reducing what we call glomerular filtration rate or kidney function as we age is not a part of normal, healthy aging. And again, we in the old days, we used to stage chronic kidney disease by kidney function. So stages 1 to 5 is kind of how we used to stage things based on what we call estimated GFR or glomerular filtration rate. And it kind of maps fairly well to a percentage of kidney function. So normal kidney function's over 90%. We really don't get symptomatic in terms of noticing we have low kidney function with swelling or feeling unwell. To our kidneys get to kind of typically below 10 to 12%. We say 10 to 20% function here, but 10 to 12%, we really start noticing a lot of those symptoms. So it's kind of a silent, insidious process before that. We define more broadly what we call chronic kidney disease, and we want to replace all the other older terminology like chronic renal failure or progressive renal insufficiency, the terms we kind of used in the old days, with this one term called chronic kidney disease. And we really define that by a couple of different parameters. And that's really, over a 3-month period, if we have an estimated GFR of less than 60 mils per minute, as calculated by one of our estimating equations, for over 3 months, or we have ongoing protein in the urine, which we measure by urinary albumin to creatinine ratio or protein creatinine ratio, or a kidney source of red blood cells, like so your abnormal urinalysis for a period of 3 months or more. And that really is how we define the disease. And again, as we said, it's not usually anything you're symptomatic with until very late in the game. When your kidneys start to actually fail, and this is again kind of that 10 to 20% kidney function range, we may notice that the first symptoms we sort of see are the fact that we get swelling in our body, and usually in the lower limbs. We may get fluid or salt and water accumulation in our lungs. The lungs fill up with water, leading to weight gain, maybe shortness of breath, that type of thing. And that's really typically how patients present as the first sign if they haven't had chemistry done or urinalysis done or that type of thing. So those are some of the signs of symptoms that we feel. The other sort of subjective things people may notice as kidney function gets really low, and again, that's just probably, again, 10 to 12% or lower, fatigue, things associated with frailty like weakness, itchy skin, difficulty sleeping, loss of appetite, nausea, and just maybe this what we call a fog kind of over the brain sometimes, but that lasts longer than 1 or 2 days. That's sort of things that we will look at when kidney function is very low, when it maybe needed time to start dialysis or that type of thing. High blood pressure is one of the main sequelae of kidney disease. So high blood pressure leads to kidney function decline, but kidney function decline also leads to worsening of high blood pressure. When the blood pressure is very, very high, and we're talking for the top number of systolic blood pressures in excess of 200 plus, we sometimes see headaches, difficulty concentrating, vision problems, but that's a very, very high blood pressure. Which we don't normally see. The ranges we're typically looking at is 160 to 180. We know in chronic kidney disease, we should be controlling blood pressure less than about 130, but these are some of the signs of very severe high blood pressure, which are strongly associated with reduced GFR. Another major thing that we get referrals for is patients have anemia. So obviously anemia, when your hemoglobin gets typically in the 80 or 90 or below range, we start getting tired, poor energy. Sometimes people with heart disease get more chest pain and things like that. And that's typically related, as I said, to poor absorption of iron, in addition to a hormonal deficiency of something we call erythropoietin, which happens when our kidney function gets typically below 10 to 20% or so. The other thing that we look at as nephrologists and the nephrology team is we get these mineral or electrolyte imbalances. This has a couple of different issues. So if we get really high potassiums, because we can't get rid of potassium while when our kidney function is low, it can cause heart arrhythmias or problems. We also, over a longer period of time, have difficulty with our trafficking of calcium and phosphate in exchange with the bones. This is something to do with parathyroid hormone. It's kind of a complex axis, but basically it can cause over time weakening of the bones, joint pains, and so on. So that's something some of the other things that we deal with in the nephrology clinic when people's kidney function gets very, very low. Just want to give you some background here on what we call epidemiology, or the statistics around chronic kidney disease. Typically, when we've done screening studies of the entire general population, about 1 in 10 people in Canada or any other kind of advanced healthcare system have some form of chronic kidney disease. Usually that manifests as most of these people will have protein in the urine, and fewer of them will have reduced kidney function. Over the last 20 years, certainly in Manitoba, we've seen a major increase in the use of dialysis and need for kidney transplants. Just because of the aging population and a higher prevalence of comorbid conditions like type 2 diabetes and high blood pressure. Manitoba, again, probably leads Canada, if not the world, in our prevalence of kidney failure. So we have, again, as you can see statistically here, a much higher prevalence of people needing dialysis or a kidney transplant than the rest of Canada. And this, again, compares with, again, some of the more severe places in the world. So we are certainly a place with lots of chronic kidney disease and kidney failure. We are growing astronomically quickly, leaving our administrative sort of struggling often to find places for patients to get dialysis. Over the last 10 years or so, our dialysis patient population grew by about 57%, despite record years in delivering kidney transplant to patients. So our transplant programs have been very active in trying to promote transplantation, but for a few reasons, because of higher prevalence of high blood pressure, type 2 diabetes, a disease that's fairly endemic in Indigenous populations that tend to get dialysis younger, people surviving longer on dialysis. We've had a tremendous growth in the need for dialysis services. And as of, again, a month or so ago, we have close to 1,800 dialysis patients in Manitoba. And again, we're following, in terms of other patients at risk of progression, over 6,000 patients in the renal program currently. But as I said, there's a lot more patients out there in the system than ones we're following within the renal program currently. I mentioned earlier the leading causes of CKD in Manitoba and most other places in the world are high blood pressure, which again, it's a bit insidious over time to develop kidney failure, but uncontrolled type 2 diabetes early in life is the main driver in Manitoba and most places. Other forms of things like glomerulonephritis or autoimmune conditions, hereditary things like polycystic kidney disease are less common and fairly similar to the rest of Canada and the world in terms of that. Heart disease is strongly associated with chronic kidney disease. If you get heart failure, we can get something called cardiorenal syndrome, which is again more rare. And then again, hereditary disorders like polycystic kidney disease or autoimmune conditions like lupus or what we call glomerulonephritis are less common, but certainly something that we look for all the time when we see patients. Everyone getting checked every year, again, that's probably a fairly strong statement. We would suggest people with high blood pressure, type 2 diabetes, people with cardiovascular disease, people who have any family history of chronic kidney disease, or people in high risk groups like if you're First Nations, should get checked every year. People at lower risk who are younger, who have none of those risk factors, probably should get checked, less frequently than that. But certainly people with these types of risk factors, we recommend being checked every year. High blood sugars are associated with, again, as I said, damage to the blood vessels, which damages the very small blood vessels in the kidneys earlier. And again, that's one of the leading causes here. Blood pressure, as I mentioned, leads to aggressive progression of chronic kidney disease, but it gets worse as kidney function gets lower. So again, control of blood pressure in chronic kidney disease patients, we recommend achieving a target of less than 130 on 80. I'm going to hand things over to our expert dietitian here to go over some of those considerations, and I'll come back to you later. Thanks.
Okay, so salt and sodium, it builds up in the body, and then the body holds on to fluid, which can cause edema and swelling, and that blood pressure then will go up, and the extra fluid building up on your body puts a strain on your heart. So for blood pressure control, it's really important to limit sodium use. So to limit sodium intake to less than 2,300 milligrams daily, and that's about 1 teaspoon of table salt. Is that equivalent? So when looking at the nutrition facts on packaged items, to aim for about 15% or less, and foods that are considered low would be 5% or less, would be considered low sodium items. But another big factor is a lot of sodium intake is actually from processed foods. About like 77% of the sodium that you ingest is from processed foods. So to choose more natural foods or foods that are cooked from scratch, so such as like the cucumber slices or chicken breast, lemon, and using herbs and other like onions or garlic to season foods instead of adding salt. In moderation, more like the cucumbers, like salad dressing, things like that, as well as pre-made foods like frozen meals, as well as like soy sauce, trying to go for a low sodium soy sauce. And then to avoid more of the processed foods like fast food and restaurant foods, things like that.
Okay, so keeping your kidneys healthy, visiting your doctor or nurse for, pardon me, for regular checkups, maintaining a healthy blood pressure, talk to your doctor about your blood pressure, just making sure those things are manageable for yourself, for the so the doctor knows what to do. Manage your diabetes. The high blood sugar damages your kidneys. Know if there is a family history of kidney disease, and taking your medicine as prescribed. Ensure your doctor is aware of any other medications taken regularly. Eating healthy, balanced meals, limiting alcohol, stop smoking, aim for a healthy body weight, and be active.
Thanks, Glenda. So we're just going to delve very briefly here into how we monitor our kidney health. And this is, again, really important because it's not done super well, even in diabetics across Canada, followed by good primary care clinics. We know that the testing for chronic kidney disease is not done as well as we should. There really only are 2 main screening tests for somebody at risk of chronic kidney disease, and they're very readily available, easy tests to get. One of them is a creatinine test, which we turn automatically into something called an estimated GFR, glomerular filtration rate. And it really is just an estimating equation that adjusts for age and sex. There are some circumstances in which it's not super accurate, but it's good enough in 98% of people to test what percentage of kidney function you're at. If it's over 60, it's just considered normal, and you only get chronic kidney disease diagnosed if it's below 60, or you have the next test, which is what your urinary albumin-creatinine ratio is. So in the olden days, we used to recommend everyone get a 24-hour urine collection for creatinine clearance and for protein. We still do that in certain contexts, but the main international guidelines now suggest just a spot test for creatinine in blood and a spot test for a urinary albumin-creatinine ratio. Albumin is a common protein in the urine. Creatinine is the waste product that comes to your muscles, and that ratio, if it's elevated above 2, it is abnormal, and as it gets a higher rate, it gets a higher risk of progression of chronic kidney disease. So those two tests are the two we ask primary care and specialty care physicians and nurse practitioners and so on to order. Really, again, as I said, they're very routine blood tests that are available anywhere in the province. We even have point of care testing equipment that we deliver some screening programs. We can do this instantly in some communities now as well. So they're fairly straightforward. In 2012, we redid the staging system for chronic kidney disease. So that I talked earlier, that stages 1 to 5, just based on kidney functions, kind of been out of date for about 8 or 9 years now. This is what the international guidelines have suggested how we stage chronic kidney disease for the last several years. And because it actually gives us an idea of how much the risk of progression is. So on the y-axis here, up and down, you see GFR. Depending on if your GFR is lower, you're a higher risk of progression. And on the x-axis here, you see protein in the urine. So as your protein gets higher and your GFR gets lower, you get into the red zone there where you're a very high risk of progression to kidney failure, which is what patients care more about likely than their actual number. Within the renal program here, we do have referral pathways to guide primary care practitioners on when and how to refer to a nephrology team with one of our sites in Winnipeg or Brandon. So using an EGFR and urinary protein, we have calculators that are available online to see what your actual patient's risk of progression is. And a lot of this engine is based on what we call the kidney failure risk equation. So it's kind of the next iteration of that two-stage system that I saw earlier. If we enter age, sex, urinary albumin-creatinine ratio, and estimated GFR, we can actually come up with a patient's 2 and 5 year risk of kidney failure. And again, we base our referral priorities on that risk threshold. And we can often reassure patients, even if their GFR sometimes is 45 or impaired, if they have not much protein in their urine, they may be at very, very low risk of progression, which is often very reassuring for patients and clinicians and so on. Just Gord now.
Yeah, Gord.
Gord, I'll let you take over a couple slides. Yeah, thanks.
Yeah, my name is Gordon. I'm a pharmacist at the Health Sciences Dialysis Unit, so I give myself a bit of a disclaimer. My specialty is in the dialysis end of things. I guess my presentation here is regarding how to manage your kidney health. So included in that is healthy lifestyle, diet and exercise obviously being an important aspect of that. We do have to be a bit careful with traditional type diets and medicine. So keep that in mind and maybe check with your treatment teams on what your traditional diet or medications include. Blood pressure is obviously another aspect that's important. Dr. Comenda already mentioned target, so we want to keep that blood pressure under the 130/80. In helping us to do that, you can follow such as low salt diets like your dietitian in the clinic and your treatment team will give you advice on. Similar with medications, the physicians will help you to adjust your medications to optimize your care and hopefully prevent problems. Advanced here, I'm not sure, there we go. Reduction of protein in the urine, we can use medications such as ACE inhibitors, ARBs. So the ACE inhibitors are things like the pills such as Ramapril, ARBs are things such as the sartans or such as Camisart. Treatment of consequences of low kidney function. So as Dr. Comenda mentioned earlier, anemia is one common thing that we tend to see. So they may start you on erythropoietic stimulating agents such as erythropoietin. They may start you on iron therapy. They may start you on vitamins to help in the anemia process. Calcium and phosphates is part of good bone and mineral health. So they may put you on binders. So diet is probably the first factor that we would look at in treating you, and then we would consider adding binders. So a typical binder would include things like calcium, renagel or sevelamer, and benzoate. And then risk for treatment of related diseases. So Dr. Comenda also mentioned heart disease treatment, diabetic treatments. So we can look at making sure we optimize those cares. Next slide. By getting your kidney health care, you can reduce your risk of problems. So as they mentioned here, no current risk to low to high. So we want to make sure that we optimize care to limit your risk.
So guys, this is just a sort of a schematic, and it actually holds very true in terms of, you can see in the blue there, if very often the kidney function will hold fairly stable, and then as nephrons or kidney cells get killed off, the curve gets very steep, and our kidney function drops off quickly towards kidney failure or need for dialysis or transplant. With a few simple measures, we can really change the trajectory of this by controlling protein in the urine. It's the number one thing is starting treatment for, as Gord mentioned, good blood pressure control. Some of that's diet and lifestyle related. Some of that involves medications. By controlling blood pressure less than 130/80, we really reduce protein leaks significantly. Secondly, as Gord mentioned, I'll just reinforce the mainstay of treating protein in the urine for the last 20 years has been ACE inhibitors or ARBs, so Prills and Artin drugs, and we've had those at our disposal for many years, and many patients with protein in the urine still don't get on them early enough. Even more recently, we've had very good data suggesting a new class of what was originally a diabetes drug, something called SGLT2 inhibitors, have been shown to really reduce the trajectory of chronic kidney disease as well. So we're recommending that certainly in all diabetic patients with GFRs above 30, that we should consider being on one of those agents, irrespective of kind of what your sugars are at that point. So that's kind of a new player that really has led to probably a 2% reduction in progression of chronic kidney disease. So we do have a lot of great available treatments that we should be applying early on in the trajectory of disease, and we can really delay or prevent the need for dialysis with the application of those. Just get slide. And just so you know, in terms of the renal program, what we've been focusing on is a number of different initiatives, both within the city, but also throughout where our risk seems to be higher in the remote and rural north of our province. We've done over the last several years a partnership with the Northwest Co-op Community Health Center doing a point of care testing, so finger pricks and tabletop devices for EGFR, urinary ACR, and counseling patients in sort of higher risk areas of the city of Winnipeg. We've done a lot of outreach with that group. We've done a significant number of First Nations community screening initiative with one program over the last several years called Finished, which we screened all the communities in the West Region Tribal Council and Island Lake Tribal Council for chronic kidney disease using the same point of care testing equipment. And we are right now launching a program called Kidney Check, which will be screening probably another 5 to 10 First Nations communities across Manitoba over the next couple of years. In addition to the same program that we've run here, we're actually coordinating across Ontario, Saskatchewan, Alberta, and BC. So that initiative is spreading to get sort of care to where it needs to be. The renal program is doing a lot of work promoting our referral pathways to primary care providers so that we can see the high-risk patients very, very quickly and refer back to primary care, low-risk patients that may not need to be seen. So our wait lists at most of our sites is actually fairly low for appropriate referrals to the center. We've had this online calculator that will help you guys decide who needs to be seen and how fast. And we continue to do a lot of research on kind of the epidemiology and how we deliver better care for patients with chronic kidney disease through the Kidney Foundation, through the University of Manitoba. There's a very large chronic kidney disease research network nationally, of which in Manitoba we're leading 4 of the projects. It's a $46 million initiative nationally, and we're doing a lot of work here in Manitoba around this problem. And then here at Seven Oaks, the Chronic Disease Innovation Center has got a number of initiatives looking at how we deliver better care for kidney health. So with that, I think I'll leave it and we'll open up for questions to the panel. And thanks very much for your attention.
Yeah, so there is a link there, kidneyhealth.ca/survey. Some of you on the webinar should also get a link as well automatically. So if you want to evaluate today, but let's see if anybody has any questions on telehealth. If you want to unmute your mic to ask a question, please do. And then I don't have any here on the webinar right now. Does anybody have any questions? Okay, so let's see what we got here. You mentioned that you provided the screenings to many First Nations communities. Will you be doing the screenings to all First Nations communities?
That's a great question. So again, as I mentioned, in the screening work we've done, about 1 in 3 First Nations people that we've screened in the communities have some form of chronic kidney disease. A lot of this is low risk disease. It doesn't necessarily need to be seen by a nephrologist, but certainly identifying this early and educating people about what they can do to keep their kidneys healthy is really important. All the screening work we've done right now has been purely research grant funded. We work very closely in collaboration with the First Nations Health and Social Services Secretariat of Manitoba, so a health arm of the Assembly of Manitoba Chiefs who actually delivers our screening program. And they're really integral partners in that. My view is that we should be screening all First Nations communities and delivering that education. We've really lobbied hard for provincial funding for this, and we've not received it. Other provinces have taken our screening initiative, and in Saskatchewan, Ontario, and I believe in BC are applying with provincial funding now, but as of yet, we do not have provincial funding for it. We've received an additional $1 million grant from TD Bank this year to expand our screening initiative. So we'll continue to try to fight for funding for this from, again, grants and private sector and so on. But certainly we would appreciate any lobbying on your guys' behalf to get the provincial government to fund this on an ongoing initiative, because it really is a really great initiative for prevention. I think it's almost an imperative for us to continue to do it.
So Catherine has a couple questions. What is preferred dose for SGLT2, and what about screening inner city populations?
So SGLT2 inhibitors, again, I've been to a lot of talks on this. It doesn't seem to matter what the dose is, so we typically don't increase the dose, just put them on the introductory dose of it. We don't see that incremental benefit from the higher dose. Maybe you do with glucose control. But from a CKD benefit perspective, I don't know there's a huge difference in the dose. So I don't tend to titrate up. And Gord, I don't know if you have another thought on that as well.
I think what Paul said is accurate. So.
Yeah. In terms of Winnipeg inner city, as I said, with the Northwest Community Co-op partnership in the city, we've done a lot of sort of high risk areas and offering screening programs in Winnipeg and the urban areas as well. Our initial data actually suggests that the chronic kidney disease prevalence is much higher in the rural and remote Indigenous communities than in inner city Winnipeg, interestingly enough.
That's all the questions that I have. So, let me see, wait, got another one. Are there plans to link point of care testing results done in communities via Kidney Check Depth Northwest to eChart?
No, if anybody screens positive for chronic kidney disease with the point of care testing equipment, we automatically recommend that they get repeat testing in a lab like DynaCare or a DSM lab, which will get onto eChart just to confirm the test. So, I think in our initial look at that, over 90% of people that got screened positive had a repeat test in a lab, which is a confirmatory test. So it's not. There's a lot of hurdles to get that point of care stuff into eChart. So right now we haven't done it yet.
No, I think we are good for questions. So thanks everybody for joining us today. And if you do think of a question later, you can always contact us through kidneyhealth.ca. But thanks everybody for coming and for our panelists for participating. And it's World Kidney Day next week. I have to give my promotion. So World Kidney Day, knowyourkidneys.ca is our campaign website. So check it out. Okay, thanks everybody.
Thanks everybody.
Thanks.
Thank you.